Good afternoon, colleagues. It's really super to see so many people join us for this, I think it's our 10th Grasping the Nettle seminar. And we're delighted on our members' behalf to really welcome Mike today to take some time to talk through that and to have such a big range of people so that we're all on the one page to really understand a lot of the things that we're already been talking about a lot, but really seeing those come together in a plan, looking at the finances and looking at how we're going to work together. So I'm delighted. I'm just going to hand straight over to Mark, and Mark Taylor is going to take us through what's going to be happening, and we'll join you for the conversation later. Thanks, Mark.
Thanks very much, Heather. Good afternoon, everyone. Wow, we've hit the ground running. We have 104 on already. So very welcome to this next NICON webinar. For those of you who have been to the previous webinars, you'll know that due to the numbers online, if you have questions after Mike presents and after Annie presents, then put it into the chat function. We will try and put people on standby as we go through to make this a conversation rather than a didactic set of presentations. If you do want to speak, put your hand up in the usual fashion, but also the NICON team are behind looking at the chat function, and we should have a really interesting discussion. We'll be putting up a link to the reset document. We'll be putting up a link to the NICON conference where, again, so many aspects of this are going to be discussed, so certainly dates for your diary. And we'll try, because of NICON representing community, voluntary, primary, secondary care, tertiary care, arm's length bodies, etc. And most importantly, those with lived experience, we'll try and bring as many people in as possible. So without further ado, I really want to introduce our first of our two speakers today. Again, needs no introduction, has hit the ground running in Northern Ireland since he's come over to take up the role of the Interim Permanent Secretary in April 2025. Mike knows absolutely everything about health services, not just in this country, but globally through many of his achievements to date. And we're absolutely delighted that he's going to give opening comments on the reset document. I'm also delighted that we're joined by Annie Bliss, who's the Senior Policy Advisor in NHS Confederation in England, and Annie is one of the senior policy advisors and led a number of areas of work, including the 10-year health plan, which was released in NHS England. And we're going to look at some of the similarities between what's happening in England and what our reset document is saying, and try and have a really robust discussion going forward. So I'm going to keep quiet, which sometimes is a miracle, and hand over to Mike. Mike, you're so welcome.
Thank you, Mark. And as always, how to set someone up to fail, but thank you for those kind words. And can I say thank you to NICON once again for giving me the opportunity to talk about this. NICON really is a special organisation, but its network and its communications are very strong. So this is a great opportunity for me to talk about some of the ideas that we've got and to get some feedback. So thank you to Heather and colleagues for that. I did have the opportunity at one of the previous Grasping the Nettle seminars to just talk a bit about why the reset was necessary and what we were thinking. I'll say a couple of words on that, but I want to focus on what the reset looks like today and how we go about doing that rather than the why of it. But in essence, as I said previously, Northern Ireland has been increasing its share of the block allocation going to health and care at a rate which, if you project forward, looks unsustainable. We're also not necessarily getting the best outcomes for the money in the way that we're spending it. And so, in essence, what we are challenged with doing in Northern Ireland is two things. One, improving health and healthcare from our existing spend, but also trying to stabilise, if you like, the extent to which we're having to spend more and more on supplying healthcare as opposed to improving health and getting earlier diagnosis, reducing clinical variation, and preventing people having the kind of problems that they ultimately present with. So this is not exactly rocket science, and it's no surprise that Annie will be talking about the 10-year vision in the English context, because pretty much all health systems across the world are facing this dilemma of resources that they're having to spend on health and care exceeding the rate at which their economies can generate the growth to be able to fund them. The good news is that I think our chances of success in Northern Ireland are great compared to many others, because we are a small system. We're covering 1.9 million population. Our leadership can get together around the single table. We have some fantastic people, and we have probably one of the best data systems now in the world, with all our providers on the same data platform. So lots of things going in our favour. I've used the opportunity of resetting the way we do the work in Northern Ireland to combine that with the way in which we spend money. So we're looking at financial sustainability as well as improving outcomes. And in order to be able to reset our system, we've looked at the evidence base from across the world as to the kind of interventions that make a difference. That points to some of what I would call the what of the reset plan. What are we going to reset? But also gives us quite a bit of insight into the how you reset systems. And so I will be talking today very briefly about not just some of the areas that we might be looking to change, but actually the way we have to go about thinking about the culture, the way in which we devolve decision making, talking about clinical empowerment as the ways in which we need to change our operating model to really be able to deliver on these changes that we are setting out in the reset plan itself. So that's what I'm going to try and cover, and I'll try and do that in the 15 minutes remaining of my slot, so we've plenty of time for consideration of the issues. So the first is, what are those areas of activity that you would look at that we've got to do differently in Northern Ireland to reset our health and care system? And obvious, and this is something that you see very much in West Streeting's thinking, but also across the world, is the idea of moving to a more preventive model. What does that look like in the context of Northern Ireland? Well, there's a number of facets there. First off, we need to join the way in which health and care is planned to the way in which care generally is planned. And I think I said on this webinar when I spoke last time that when you look at the things that drive the wider determinants of health, things like somewhere to live, someone to love, something to do, all those three things really relate to other organisations and the way in which we work with colleagues in local government, in employment, in housing. And so joining up our AIPBs, our Area Integrated Partnership Boards, into the care planning process is a commitment that we're making as part of this reset. But alongside that, we're trying to change the dialogue that we have with the public about how they are part of the process of health and care themselves in managing their own care and helping their families, etc. Very much the way that we saw through COVID. And of course, this is one of the great opportunities that we have in the modern day health and care system, is to have a genuine partnership with citizens, ideally before they become patients, in terms of managing their own health. And we signal in the reset the idea of a programme called This is Health, which is the beginnings of our approach to using behavioural science rather than perhaps some of the traditional public health messaging to connect to people about what is a something for something deal look like in the context of Northern Ireland, i.e. if we can help people remain healthy, then that allows us to target our resources when they do need us to make sure we can meet their needs in a timely, perhaps more rapid way in which we have been able to do up to the current date. So the preventive agenda is hugely important to us, but it's both primary and secondary prevention. And that takes us into the second area of reset, which is really the idea of building an out-of-hospital integrated, joined-up provider offer for citizens who do need help with a problem that they might face and can't cope with it on their own. And this is really, I think, at the fundamental heart of most systems resetting reform programs, is what does that model of care look like out of hospital? We've used the same term that you'll see in an English context, this idea of neighbourhood. There's a question about the logistics of that, what kind of size of population is covered by a neighbourhood. But in essence, what we're trying to do here is bring together the voluntary sector, community pharmacy, general medicine, general practice, secondary care, social care, mental, physical support, so that when people sit around those tables thinking about how they're using their current resources, we can use those in a more joined up way with some degree of governance and sharing of budgets together to use the resources we do have and the data that we have to get the resources to the right people. And I very deliberately include our non-statutory sector there, because we know a huge amount of benefit can be gained by our voluntary community services, but also this isn't just about shifting the pressures, if you like, out of hospital onto hard-pressed generalist support in the community with community nursing and general practice and community pharmacy. This is actually about bringing the resource currently spent in acute care into community settings. And we know from places like Jönköping in Sweden, Alzira in Spain, Canterbury in New Zealand, that where you do get this combination of service providers working together with a single purpose of maintaining people in their independent lives to live independently and avoid hospitalisation, that there is a huge amount that you can do to deliver added value to the care to the way in which we spend our money now. So that neighbourhood model is no surprise, but what we will now do over the coming weeks and months is work with our colleagues in those sectors to design a model which is fit for purpose in Northern Ireland. And I'm very confident with the cohesion of our communities that we can have a genuinely integrated neighbourhood approach that really does manage an awful lot of the work which is currently finding its way into hospitals or the care sector that could be done whilst people are living in their own homes. So that's a sort of third area. The fourth area is looking at our areas where effectively we need to take a whole systems approach. And this is using the whole of the assets in Northern Ireland, all our estate, all our workforce, to think about how you could use that collectively. And certainly we're already seeing the establishment of a committees in common structure in Northern Ireland, which allows our trusts to take a shared decision around the same table and be able to get that consistency of approach in each of our trusts, which would also include tackling the clinical variability that we see and making sure that all our providers are performing at that upper quartile level, that we're using the data that we have through things like GIRFT to tackle inefficiencies in our service, but also to optimize the resources that we have. And certainly that is a big step forward in terms of whole system working. And again, NICON have been very supportive of that model, as have our trust boards. And alongside that is really thinking whole system, using the resources that we have in return for cross-government support on prevention to really help them. So things like, how can our resource help reduce reoffending? How can we deal with some of those challenges the police have about people presenting on our streets with mental ill health problems in chaotic states? How can we use our resources to support management of special educational needs or educational attainment? And how can we use our resources to generate inward investment in terms of life sciences, jobs, and innovation? So that whole systems approach is very much something that the reset stresses, with a whole variety of ways in which that can help deliver, if you like, the Minister's stabilisation, reform and delivery agenda that he set out in his 3-year plan by getting the system to work together. And indeed, Rafael Bengoa's title of his report many years ago was Systems, Not Structures. So really thinking about whole system working. I mentioned the opportunity we have with digital and data. We've now deployed the Encompass programme, and that's present. We have to now move very swiftly into managing, if you like, to get the benefits of that. Data really is the sort of key ingredient for a modernised health and social care system using our resources well, and we will certainly be using the Encompass data to help us target the resources at those with greatest need and risk. And I think the opportunities there are really phenomenal, but we've also got to help focus our delivery of change capacity to take the opportunity of that data. And then we come on to things like innovation and life sciences. We know that if we could innovate faster, we could probably get immediate added value. I sometimes estimate between 15 and 20% added value around our drug spend, our medical technology spend, simply by being more innovative and adopting some of the better practices sooner. And we have some great work which will emerge with our universities, with Hirani, with our commercial partners. And really, as I've said on many occasions, this reset plan states that Northern Ireland is now open for business. Come and talk to us if you have ideas that we should be thinking about. Now, all of those in the plan, all of those ideas in the plan start to get into how do they underpin stabilisation, how do they underpin the reform agenda, and how do they underpin the delivery commitments that we would make. I've not mentioned the key issue of financial stability and security, but effectively what we have to do alongside this reset plan is really look at how we can get you the most efficient use of resources. And that's looking at avoiding locum costs, reducing agency spending, thinking about how do we get the care pathway so that we're tackling people at the earliest opportunity, which is very often the cheapest opportunity in terms of our expenditure. How can we look at productivity where we do need secondary care to get more people through our operating procedures quicker and sooner? How do we optimise our medicines? So there is a whole raft of programs of work to really look at efficiency, both technical and allocative efficiency, that alongside the reset plan start to get our cost base and our run rate into the right shape so that over time, and the finance department will be trying to publish a 3-year vision running through the mandate, the next mandate, that actually show how Northern Ireland would use the multiple year budgets to best effect. And we have to commit to that. As we say in the reset document, we can probably only go so far. We'll need help from our executive colleagues in terms of supporting us in that journey. But if they can help us in the short term, we're very confident that we can get the full year benefits of our approach to be able to manage within our resources at that and try and optimise and cap at that 52% level so that we're not completely coming back effectively robbing some of our approaches to a healthier community in the short term, and then finding ourselves with additional demand going forward. So we are talking to exec colleagues as we speak, and the politicians have got some difficult choices to make. We appreciate that. But there's a real opportunity in Northern Ireland, arguably for the first time, to see how we can really reset the system to live within its means and produce the better outcomes. So that's really the kind of what of the agenda. I just want to sort of talk very briefly about the areas where we have to work differently and what that means in terms of our culture and our support. And I'll run through these very quickly, but I'm happy to have a conversation with anybody going forward about what they mean in practice. We have to operate as one system. We've talked about this a lot. The reset plan commits to how we do that. I've already talked about committees in common, but we move away from the parent-child of department to HSC. We take mutual responsibility for our relative contributions of getting great policy that creates the right context so that we can deliver great care on the ground. That means getting the decision-making devolved to the right levels. We don't have the complexity of the English NHS, which has a lot of things about incentives and tariffs and ICBs, etc. This is really about getting clarity of where those decisions get taken and really enhancing the trust boards at local level to be making those decisions and to be accountable for them. We have to have improved clinical engagement and empowerment, and that's something which is a cultural point, but many of these approaches of transformation and reset need clinical leadership, and I'm glad that we have a number of clinicians on our call today. We have to invest and support our leaders, and we have to generate those people with the capacity and capability to take on the challenges leadership. As many of us, certainly my age, come to the end of our careers, we have that hunger, that desire, that enhancement for those leaders of the future. We have also to be very open and honest where we fail. And you've seen over recent months, there are some issues about quality and safety in some of our services, and we need to be able to be honest with people. We have a number of public inquiries coming up that are reporting in the next couple of years, and we have to be very honest with the public about where we've not been able to deliver to the standards that we would aspire to, and apologise for that, but also learn those lessons. So a commitment to openness and transparency is very much part of the reset of culture. And crucially, we have to set high ambitions for ourselves. This isn't about aiming to be in the middle of the pack. I am absolutely convinced Northern Ireland can leapfrog other systems and have that world-leading system. And just alongside that, perhaps in terms of bigger cultural shift, we have to really kind of have a confident, empowered workforce that feel valued. We have to continue to pursue the efficiency of every pound we spend so that we spend every pound wisely. We have to get some simplicity in our oversight and clarity of decision making. And then, as I've said before, we have to work across the government to make sure we're supporting other government departments. There are lots of things that we have to do in this reset plan. I do not underestimate the pressure that this plan is putting on managers, on docs, on nurses, on therapists, on our staff, our admin staff, to change the way we do things. But if we don't aspire, we won't achieve. You know, the limits of our ambition are very often the limits of our aspirations and our achievements. They curtail us. We've got to aspire to greatness. I've had a great response to that, and I'm very confident that people on this call, whilst you might have some practical questions, everybody's really committed to that single purpose of having a health and care system in Northern Ireland that's the envy of the world. But in order to do that, we have to reset the way we use our money, and we have to reset our priorities in the way I've described. So listen, thank you very much for your participation in this seminar today. But more importantly, as we go forward, can you be part of that solution? Can you be part of that story of leadership and change? And if so, you know, and we can count on each other to deliver that, the world's our oyster. So thanks very much, Mark. Hopefully that's given us some food for thought. We'll be happy to take comments, challenge, questions as we go into the next phase of this webinar. Thank you.
Mike, thank you so much indeed. And I think all 177 people on this at the minute will agree with you about that inspiring to greatness. And I completely echo your comments that we have a definite opportunity here in Northern Ireland to do that. You've covered so many aspects of preventative medicine, neighbourhood approach, the whole system approach, committees in common, which I'm sure we'll want to explore. The whole issue of innovation and working with industry and looking at income generation, I think for many of us is an exciting area. You're absolutely right. You've mentioned the digital, and I see many people on this call that are familiar with the Encompass rollout, and really having that open, honest conversation and collective leadership, which you've mentioned. I'm going to come back to Kathy, because I think Kathy's question really around co-production, and I know you have a few points to make, Kathy, we will come back to, because I think it's as equally important, and I know you'll have heard Mike reflect on the essential component of the lived experience view, not just at neighbourhood level, but as a whole system approach. So first of all, I'm going to get a reflection from a chief executive. This is really just to get everyone ready to start to ask their questions, start to put their comments in. But clearly, we have heard about the committees in common that Mike has mentioned. We've heard about a one system approach. Roisin, I'm going to bring you in first. Thoughts on what you've heard about Reset so far?
Yes, thank you very much. Thank you, Mike and Mark. And it's absolutely fantastic to see so many people joining yet again in terms of our Grasping the Nettle webinars. And hopefully many of you will know me. I'm Roisin Coulter, Chief Exec here in the South Eastern Trust, and I'm the Vice Chair in NICON, and working very closely with my Chief Executive colleagues right across all of the provider trusts in Northern Ireland, but also all of our arm's length bodies as well. So I suppose what I would just want to share with you just for a couple of minutes is that we've been working with Mike and the team for the last number of months, really, in terms of planning, providing our input, helping to shape the Reset plan. So to get to today, where this is now being published and launched, I think it is fantastic. But for all of you, I suppose, as colleagues working with myself here in Northern Ireland HSC, is to say, you know, this is our plan. We need to own this. And I am absolutely up for owning it. I would encourage everybody who's working as part of the HSC family to really say, right, everything that's gone in the past, now is the time genuinely for us to stand up and to work together as one system to really shape that change and reset health and social care here in Northern Ireland. We definitely believe we can do it. Over the last number of years, the last 3-4 years, probably, to be honest, using the opportunity brought to us from managing COVID. And remember, our response to that was as one. And that really is the spirit in which I suppose the group of chief executives have continued to work, in a spirit of that we are one collaboration, one forum, that whenever we are asked to input, to advise, to go forward, that we are definitely going forward as one. So it will be one voice, one consistent message. And that is really, really important, because that's what our patients and our public need to hear. They don't want to hear so much in terms of variation, whether it's managing and supporting staff working right across HSC, whether it's our citizens who use our services. They don't really mind, you know, how many trusts there are, arm's length bodies. It's really about what does this mean for you, and how can we help you live your life the way you need to. And I think that there are a number of things here in terms of the NHS plan that's, you know, now been Northern Irelandised, if you like to say. This is what it means for our country, for our 1.9 million, and how we really want to genuinely get greater grip at scale and pace and really move forward on actions. And it has been difficult over many years, as many of you know, with political environment, media environment, you know, really a view that, you know, there was an unwillingness to help support transformation and change. But now there is that real opportunity for the shift from the hospital to community, analog to digital, etc. We've done so much in that space, and really patients more as active partners in their care. And there's so many people that I can recognise on screen today, our partners from our arm's length bodies and community and voluntary sector, patient client council, who are absolutely in the one space. So we are driving forward to work as the 6 large trusts with our chairs, our chief executives and our senior leaders to form a shared committee in common. And that is going to start to meet from August of this year. And that's where really we will come together as one team, one group, and we will be able to debate, discuss, work with our clinical teams and our professional groups to take shared binding decisions that will apply right across Northern Ireland health and social care services. So that's something that is really positive, and it's a vehicle by which we can take a decision as if we are working as one. So we don't all have to be in the same organisation, because we can work through the committee in common. And some of the things that we're going to be looking at, and I know many of you are saying, well, Roisin, you know, so what? What exactly does that mean on a practical basis? Well, look, we've already worked together to set up the Regional Control Centre for Northern Ireland in terms of managing flow across the system. We're looking at an umbrella under the Committee in Common for provider collaborative arrangements, where again we can work as one team, looking at waiting lists, for example, including gynecology, looking at home care and social care, models, tariffs, etc., as one as well. And there are lots more opportunities where we do want to come together and work in partnership with Department and SPPG, BSO and PHA, who are key players in this, to really look at, if we were doing this as we're one team with our shared workforce and our shared resource, that we will be able to drive forward with, I suppose, getting more greater efficiency, but also reducing clinical variation. So again, that's something that we can build on, listening to our clinical teams who've been doing that already through Encompass with standardised clinical pathways, etc. So it does all link in together. And I think as well, it'll be very helpful, hopefully, for our neighbourhood focus and supporting AIPBs in terms of greater work at place level in Northern Ireland as well. So really seeing, can we really get more traction on that? So I don't want to take up any more time, Mark, but hopefully that's a good reflection and where we are and some of the practical things that we're trying to do to work together already and build on that as one system approach, and would encourage everybody to really get behind this now and to say, this is it. It's one message coming out. Doesn't matter whether it's a politician, whether it's the media, whether it's a member of staff or a member of the public, that we've now got the reset plan and we need to drive it forward and implement it.
Roisin, thank you so much. And again, we've got 182 people online, so please put your comments in, put your hands up if you'd like to speak. We'll try and coordinate it. I'm going to put Steve Sporry on standby, but I'm going to go first to Vivian Toll. And Vivian, Mike has talked a lot about clinical variation. We've talked about our workforce. I am going to come back to primary care. So Siobhan McAtee, you're also on standby, because ultimately at this present time, there does seem so many pressures. And whilst we do have this aspiration, and I totally agree with the ability for all of us to inspire to greatness, what's your comments from a sort of workforce point of view on the reset document?
Thanks, Mark. And thank you, Mike, just for that overview in terms of the reset plan. There is something really inspiring just around what we're hearing and what our plan is across HSC. And there's something that really resonates with me around, if we don't aspire, we won't actually achieve what we need to out of this. And it feels, I think there's recognition, Mike, from you that it is a tough place for a lot of us and a lot of our clinicians and a lot of our managers out there. So there's something about how this reset plan starts to get a bit of hope back into the actual system. There is something around the one system approach, and Roisin, you've referred to it there in terms of the real importance of one team. And that one team and that one system approach is going to be really, really key around some of our workforce challenges. We've already started to sort of see the benefit of where we have worked together as one system around some of the agency reduction work. And that kind of collaborative approach where we're all in this together and we all need to do the right thing and keep each other honest. So we've had a bit of a track record with that, obviously, with the nursing agency. That absolutely needs to continue. We're in that space around our medical locum work. And as a group of HRDs and directors of finance and operational service directors, we are fully committed to making sure that actually as a system, we are working together, because unless we all stick to the one plan, we're not going to achieve what we need to do, which ultimately is the elimination, obviously, of agency. There's something as well around, you mentioned about the investment and support for our leaders. And as I've said, it's a tough place out there for our leaders and our managers at this point. And we know, Mike, you've started to do a bit of work with colleagues across our system in relation to that. I suppose a concern is about losing so much of the experience and that sort of corporate memory around HSC over the next number of years. So the investment in the development of talent is going to be really important, and just you have our commitment as HRDs to work with you and to work as a system and really collaboratively on that. because that is going to be really key moving forward. So Mark, those are a couple of things just I suppose that really stand out for me.
Thank you.
around,
Thank you
what we've heard.
so much, Vivian. And I'm just going to come back to Mike. Mike, any comments just on our first two contributors before we go and look at two areas, primary care and finance, and again putting Emer Macaulay on standby?
Only just to sort of echo Roisin's point around, I think you'd had questions on co-design. Maybe it was Kathy who was raising that. You know, setting out a framework like this, we've had discussions. I was talking some of these ideas through with chief execs, possibly going 2 years ago. You know, they've been incredibly connected to this, and you know, I've been really grateful to them for their commitment and support. And you heard that from Roisin and Vivian, that some of the ideas in here, you know, this essentially is a reset plan which is produced by the Department of Health, but its entire existence and what's in it and how it'll be implemented is really with the HSC and partners. So I was delighted that Roisin referenced that. I think that has to be a feature of the way we implement, not just the way we came out with a plan. So I really genuinely believe that people on this call will be party to making the implementation of the ideas a reality on the ground. And it will look very different in the middle of Belfast, or you know, in County Fermanagh or whatever. So that you know, this has got to be something that's owned locally, and that spirit of co-design has really got to take place. So we have to continue at my end to listen to what people are saying to us, and these calls, these discussions are essential from a leadership point of view. So just comments on that so far, Mark. I'll certainly come back on primary care, I guess, because there's a couple of things to say on that. Yeah, thanks.
Sure. And just before I go to primary care, I'm really delighted Steve Sporey has joined us. And for those who are not familiar, Steve is the interim chief executive in the Southern Trust. And I suppose, Steve, we've heard from Roisin, but you have come from NHS England as a senior leader to Northern Ireland. And I just wanted to hear your reflections on what you've heard about Reset. And Steve, maybe microphone, sorry.
On mute.
Yeah, that's you. Excellent. You're back in.
I'm back in, am I? Oh, good. So thank you, Mark, and hello, colleagues. I've been working in Northern Ireland for about 16 weeks now, so I've been learning quite a lot, and I've been asked to talk, I think, particularly about things I observe that can help us with this reset. So what have I noticed, really, apart from the lovely weather? I think one really important thing to say is people are very friendly, right? Now, friendliness is nice, but it's also a superpower, right? Because friendliness encourages cooperation between people in all kinds of different areas of work, and friendliness enables open communication about things. And as Mike said, we're a small system. We can, if we're able to talk in an atmosphere of trust and cooperation, we can make big changes quickly, right? We don't need to invent the architecture of complex leverages of accountability and incentivization that much larger systems with much more formality in them need to do. That gives us a great opportunity. I also notice, of course, in Northern Ireland, we combine social care with healthcare. Right? And I ask myself, so how can we really leverage benefits from that in terms of helping people to regain functioning, in helping people to avoid attendance or admission to hospital? And I do think that we need to do something significant to ensure that clinical teams and organisations are incentivized to do greater do, what am I trying to say? To achieve a greater level of productivity, to put it simply, to treat more patients at lower unit cost. Can we do one more patient per operating list, one more outpatient procedure, etc., within the same clinic or the same list? Because we have some pretty terrible elective waiting times. And I think we can do an awful lot better there if we really think through and talk through in that open way how it works for everybody, right? But we want to be in a virtuous circle where people believe that if we work more efficiently, we'll be able to develop our service and do better for our patients, right? That every step forward enables the next step forward so that we continue to make progress. Now, I arrived and immediately discovered everybody was talking about Encompass. And we've been implementing Encompass, of course, in early May in the Southern Trust. It's fantastic. Northern Ireland's got one common record system. Again, that aids that cooperation and that friendliness potential. It means clinicians anywhere can see timely information about a patient who has been. And if we can really work on an interface with EMIS as our primary care system, we can do some pretty wonderful things, I think, about changing the location of care and about changing the profile of demand. So we've really got to work on that. And the other thing we can use Encompass for, particularly in conjunction with Epic, is turning data into analysis, an analysis that informs all of us, that informs clinical teams, because most of the time, if people see good quality, comparable, meaningful information, they'll spot the potential to improve. And they'll pick it up and get on with it and produce better clinical results and lower unit costs, etc. But also informs the system about where does it need to change its configuration and put less resources and put more resources and reshape total pathways. So there's a lot to go at there. But I really believe we can make a lot of progress very, very quickly. If we all believe in ourselves and in our colleagues, and if we approach it in that spirit, friendliness, and cooperation. So thanks. That's what I've got to say on it.
Thank you very much indeed, Steve. For those at the Open, you would have seen the friendliness and support of Rory McIlroy for all to see. It just wasn't his day, unfortunately, Steve. Thank you. We're going to go into one of the, I suppose, elephants in the room, if you want to say that. And I see your hand up, Jonathan. I'll come back to you. And that is, and we've heard from Nicola Heron in the chat function. I see Roger Kennedy. I see a number of general practitioners on the call, and we're only very acutely aware of the pressures of being a general practitioner at the present time. And we obviously have the reset document looking at neighbourhood approach, shift left, population health, multidisciplinary teams. So I really just want to take a flavour from Dr. Siobhan McAtee, one of our general practitioners, just really to start looking at a little bit of the conversation about primary care. Siobhan.
Thanks, Mark, and thanks, Mike, and the other speakers. I suppose when I looked at the reset document, the one thing that I took from it was hope. And I think we have to have hope for the whole system, for our workforce and for our patients, because at the minute we're in pretty dire straits. Regarding the reset, I think it's especially important that we are inclusive and we build on collaboration that's already there, including part of our Working Better Together work that's already been done to make that joined up working approach. This presents a really good and a timely opportunity for general practice to help reshape the future of healthcare. All those words are very common to general practice: prevention, neighbourhood care. That's all our bread and butter. But it is a difficult place out there, and we need to have a robust primary care that is able to deliver upon this. And that is the one area I would think too. You know, with the rollout of MDTs, at the minute we have a very unequal system with only sort of, there's going to be 8 out of the 17 federations with MDT. So we're not talking across an even patch, but it'd be really good to get this going. If we keep doing what we've always done, we will get what we've always got. So we really do need to reset and change and start again. As Mike said, we are a small system. We're 1.9 million people. We should be able to make this work. And there will be, economies of scale. So I think GPs are massively positioned to help and to lead on this. I mean, prevention is our bread and butter. We work in neighbourhoods, and we very much do what everything is that is in the reset team. And the one thing I would say, which Vivian alluded to, was the development of leadership. It kind of happens certainly in primary care in spits and spurts, where there's a course here and a course there. We need consistent succession planning. Because we don't have the same flow of GP leaders that are coming through. We need to continually maintain that. And federations are an ideal position to carry out that neighbourhood. Manchester neighbourhood is about 60,000. Federations roughly have about 100,000 patients. So it would be useful to compare the two areas. Does that help, Mark?
That is perfect, Siobhan. And just before I bring Mike back in, and then we're going to hear from Annie, and then we're going to have a real open fire question and answer session from everyone and anyone. And we have a few already. Marion and Kathy have indicated they'd like to come in. So Emer, finance has been mentioned. We want to stabilise primary care. We want to stabilise prevention and neighbourhood approach. And you are trying to balance your books in secondary care. How's this all going to work out?
Well, Mark, thank you very much, and Mike and everybody else. And can I start by saying that I do fully agree with the comments previously made by Roisin and Vivian and Steve. We have many examples in HSE of how we're working as one system. We have been highly successful, and we have to embrace that opportunity and the agency that we have to do more in that space. And I can tell you, as someone who participates in Healthcare Finance Managers 4 Nations Network, our size in Northern Ireland is one of our advantages and very much lends us to leverage much more efficiency across our system. But as you've said, Mark, we really are grappling with the financial challenges that we face. And very often we can be guilty of pouring water on the fire of today's burning platform. But meanwhile, Rome is falling down and burning around us. But there are 2 important messages coming from the reset plan, which are both inspiring and reassuring. And these have been alluded to by Mike already. The first one is it's important that we do not let some short-term funding pressures become a barrier to medium and longer-term investment, especially where the investment is critical for reform and service improvement. So it's really important that our system is calmed by the recognition that we are not here to make quick band-aid style decisions. We really need to have a much more strategic and better informed focus on what is the vision for health and social care for Northern Ireland, and how do we protect that vision as we're navigating very challenging times today. And the second part of that is the important part of that is the recognition that the reset plan makes it clear that executive support will be needed to meet some of our immediate pressures and allow us to build those foundations for a sustainable budget position going forwards. Really reassuring, because the scale of our deficit today and the ambition of the reset plan is such that for us to deliver on the reset plan fully and effectively, we have to be strategic and we have to be responsible, and that's just going to take a little bit of time. And we know that the Department of Health in England have already taken really difficult decisions in order to create the investment that they need for their front line. And Mike really helpfully described the how for us, which will include getting the best use of our resources, the revised care pathways, productivity through secondary care, and the optimization of medicines as some of the ways that we will do this. And recognising both technical and allocative efficiency improvements will start to get our cost base down and our run rate down. And these are all part of how we will stabilise the financial position. Absolutely the type of strategic and responsible leadership approach that can deliver sustainable financial stability for the future. I can speak for HSC finance staffs when I say that we are really up to support this way forward, and all HSE staff will have a role in delivering on this agenda. But it does take grit and courage and in our system to enable and support some of the big decisions which are going to have to be taken. So the challenge for us today is how we can collectively do more now in order to help square that circle at the pace that the system needs it, and have confidence that this reset plan will deliver on the financial sustainable stabilisation that we need going forward. Thank you, Mark.
Emer, thank you very much. And for all the young people on the call, the instrument that's on Emer's desk is called a calculator. It's always good to see a financial director has a calculator. Look, some really important comments. I'm going to come back to Mike on primary care and finance. Then we're going to go to Annie, and then I really would like the rest of the session to be as many people that we can get in before the 4:30 close to ask Mike, ask Annie, challenge, make comments, etc. And I know we have a few already in the pipeline. So, Mike.
Yeah, thanks, Mark. A couple of things that are really important. First, on the money, just to say, I did smile, and Annie might comment on this. The NHS in England has put £29 billion of additional resources. Well, the Treasury has given £29 billion of extra resources over the coming period, which will be available to implement the 10-year vision. We have minus 600 as we speak. So we're in a slightly different financial position. And in fact, even then, the NHS in England said it wasn't enough. So that tells you the scale of the challenge that we face in managing our money alongside delivering change. But we have to be positive. That is an even greater need for us to change and arguably faster. But it is a management challenge. I want to say something about primary care. And first of all, Siobhan, thank you, because those comments are incredibly positive. As people know, we are in a dispute at the moment with GPs, which is incredibly sad. I mean, I'm a very proud honorary fellow of the Royal College of GPs. It was a great day when I was given that award. I also was the person who negotiated the 2002 contract. And the way I would try and address this for GPs out there now who are taking the view that some of them have, that no one loves them and no one values and realises the pressure that they're under. In 2001, I could have been under pressure at the time to put resources into stabilising the old Red Book, which was a fee-for-service, very regressive kind of system of payment. Instead, we chose to offer the opportunity of a new contract, a new negotiated contract that made general practice fit for the future for a period of time. And I admit that contract and QOF, was really helpful in the short term, but it needed further evolution and change probably before the last 22 years. So that's timely. But what we've offered here is the opportunity not to put money into the old Red Book, but to think about what a new contract looks like going forward as you build a neighbourhood model. And we know, and I know we've got colleagues on the call, there is a huge amount of workload that's going into general practice at the moment that could be dealt with better with voluntary sector support, with community pharmacy support. There's also a workload which GPs are trying to manage, which if we can get our acute secondary care boundary and primary care boundary done better, then effectively, we can move that away from a specialist generalist to a specialist approach very quickly and actually get better value in whole lifetime costs of care. And then there are other areas where general practice is having to manage things that are social problems impacting on chronic disease as well, which the MDT approach is trying to tackle by offering access to social care, mental health, physiotherapy, etc. And we can build on that through social prescribing. So my offer, if you like, in the reset was to open up conversation, not just on negotiating a new contract, but helping to design a new contract. And anybody who's a student of history will know that after I was involved in 2002, there was a 3-year period when it's the only time in NHS history in England where more money went into primary care as a percentage of new money available through growth than it did into secondary care, because we were effectively backing a model of chronic disease management. So I'd just say to our colleagues, you know, this is an incredibly difficult financial year. We weren't able, beyond the money that we have committed to put £80 million into more of the same. But actually what we really are offering here is an opportunity to put future resources into a new model of care that actually will be a combination of remuneration, which is important, but workload management, which is also important in terms of stress that general practitioners find themselves under, and offering them a chance, along with colleagues, to coordinate care in a neighbourhood in the way that Siobhan saw as inspiring and exciting. So I just hope that colleagues can keep the faith with us that actually we are genuinely trying to invest in out-of-hospital services in the interest of general practice, rather to put more money that we simply don't have this year into more of the same. And it is disappointing we're in the position that we're in, but hopefully we can come back to the table. Well, we're certainly offering the opportunity of coming back to the table to design that new future, which I think will be a more satisfying future for general practitioners working with colleagues as equal partners than the one of simply putting money into the current contract. So I just thought I'd use this opportunity to describe that, and hopefully some people have heard that and can talk to their colleagues about that. Thanks, Mark, for that opportunity.
And thank you very much, Mike. And I'm sure those words, which I know will be associated with absolute actions, will offer some comfort to our primary care colleagues at this time. I want us to take a short interlude, because I think it's really important that when we sometimes focus in on Northern Ireland, we don't sometimes see the bigger picture. And I'm absolutely delighted that Annie Bliss has joined us from NHS Confed, and literally just hot off a Confederation discussion on the NHS 10-year plan. So Annie, just a few thoughts while everyone starts to get their questions sharpened around your reflections on what you've heard from our Permanent Secretary about our own reset and some of the thoughts around the 10-year health plan.
Absolutely. Thank you, Mark. Really interesting to hear from Mike and other colleagues about some of the changes you're embarking on in Northern Ireland, kind of what that means for healthcare leaders. So I'll start by setting a bit of context just for those who aren't as aware of the English 10-year plan, and then introduce some of the parallels, I think, with the reset plan. So might want to just circle back after I've spoken in case there's any points that I have raised that actually are covered in other strategies and plans. So I've read the reset plan, but it might be helpful to circle back on that. I think the good news is that there's a great deal of alignment really in the approaches that are being taken, with some, different flavours. So our plan is 165 pages, so we're still kind of digesting some of the detail. There's lots of different ideas in there and lots of key kind of changes. We still don't know everything at this stage, so I think one of the central tenets of the 10-year plan is a move towards less prescription, a more sort of permissive, hands-off centre. So we're expecting to get a bit more detail on some of the delivery, but a lot of that, similar to the approach being taken in Northern Ireland, is going to be very much co-designed and locally determined as well, which I think is extremely positive. And that move towards a kind of earned autonomy environment. So we will have, we've got a neighbourhood health programme that's kind of just launched, looking at the implementation. We've got our planning guidance where a lot of the detail around delivery will be contained, and then some kind of, I call them sequels to the 10-year plan. So there's a refresh of the long-term workforce plan, cancer strategy, mental health strategy, etc., etc. So I think generally we think as the Confed that the 10-year plan is very much the right vision. So we've got the central 3 shifts from hospital to community, from treatment to prevention, and analog to digital, which very much align with the reset plan focus as well. They're not new concepts, but I think the thing that will be kind of novel this time will actually be kind of committing to them. And I think a lot of the enablers that sit beneath them will enable that, and obviously the political commitment to get there. And I think hearing some of the language again that Mike shared, it's very much the politicians in England are saying around this being kind of very much the last chance to make sure that our model of care is viable. So I think, yeah, we've got the vision. The delivery will be very challenging, but there's a lot to play for, and we'll see a bit more detail in the coming weeks. I think one of the key differences with the English plan is probably around the operating model is a very, very explicit devolved operating model, and attached to that, within this concept of earned autonomy, there is quite a robust success failure regime. So if you become a high performing provider or an ICB, integrated care board, you can kind of unlock new freedoms, but attached to that there will be increased transparency around performance with the public, and so there's opportunities there to kind of for example, to move towards outcomes-based contracts for a local population. So an ACO type model is kind of written into the plan as a potential, but I think some of this stuff, you know, it's a 10-year plan for a reason, so we might see more progress towards that in the kind of second half. And I think that there's possibly actually in the Northern Ireland reset plan a bit more in terms of kind of the capabilities and that softer stuff around, you know, how do we support leaders, that I think we hope is there, but wasn't as much of a focus in the document of the 10-year plan. There was quite a lot on capital as well. So there's a lot in the plan around digital data and technology, and obviously we need a lot of capital to kind of to enable some of that. So the 10-year infrastructure strategy was another one of the documents that came out ahead of the plan, and that opened up the possibility for more public-private partnerships to be able to unlock some of that capital. So I think we'll need to see a lot more kind of flexibility in being able to access that capital and having that self-sustaining mechanism for doing so. I think another interesting comparison, there's a lot of focus on sort of electronic patient records, expanded use of the NHS app to enable the public to be active agents in their health and their well-being, similar to what Mike has just presented. I think probably there's an extent to which you're a bit further in Northern Ireland on some of this stuff. There was not as much as I was expecting in the plan on kind of some of the infrastructure that might enable some of the data flows, data interoperability and things. And also there wasn't enough, in our opinion, on how do you enable patients and staff to actually be able to use some of those technologies. So I think that there's a digital plan that you have in Northern Ireland, but that detail is lacking at the moment in England. And then another obviously key difference, there wasn't anything on social care. We obviously don't have an integrated model of health and social care in England. We've got Baroness Casey undertaking a review at the moment, and we're absolutely clear that until we have you know, a viable funding model for social care, then you won't be able to deliver things like neighbourhood health effectively in the way that is intended. So I suppose the English plan is a bit broader in scope, understandably, given the kind of scale and the complexity, given the timescales as well, over 10 years as opposed to 3 to 5, looking at a lot more around digital innovation and shifting to community-based preventative care, a lot around kind of genomics and AI, and kind of health innovation to unlock some of that economic growth as well. So I think you said it as well, Mike, you know, all healthcare systems are facing this perennial issue of a large amount of demand for care. And so both plans kind of recognise that there's limits to public funds available to meet that demand for healthcare. And I think probably different challenges, as you outlined, in terms of the deficit that you're facing, but I suppose the kind of the scale and the complexity in the English system is going to pose some challenges. So there was a bit more in the English plan around shifting funding cycles, moving away from block contracts and those sorts of financial flows, And then kind of attached to that, there's a bit more kind of, there's a productivity index, for example, but there's also sort of financial penalties and things attached to that. So an element that English leaders will have to kind of grapple with, I think. In terms of kind of system working, both plans recognise that you need a kind of a whole government approach. So healthcare is only one element of people's health outcomes, and you need to make sure that there's a focus on well-being and other social determinants like employment and housing. I was quite struck by Steve's comments about the kind of perhaps cultural differences and the friendly open culture, meaning that some of that collaboration isn't necessarily needing to be artificially enabled through kind of financial and regulatory incentives. But obviously within the English system, there has been quite a big kind of reorganisation that happens halfway through the plan was being developed. So I think at least for now in Northern Ireland, you can be grateful for the focus on not tinkering with the structures, but actually looking at what are the core foundations for change. Big focus again on neighbourhood health. I think the main difference, obviously being that social care is integrated in Northern Ireland, there was quite a big focus on sort of neighbourhood health centres and some of the infrastructure in England. And again, there's going to be quite a big national implementation programme where we'll get a bit more detail on that. And obviously a lot of funding to set up such centres. So just exactly how that will be done over the next sort of 3 to 5 years and beyond will be interesting. I think reflecting on what was in both plans on prevention, perhaps a bit more of a fundamental shift in the reset plan in terms of the expectations of citizens. Obviously a difficult conversation to have as a politician, isn't it? But I think that was something that we were hoping to maybe see a bit more of. Lots of measures on obesity and smoking and vaping and things in the 10-year plan. And I think possibly, mentioned about this health programme, possibly easier to kind of do a public health campaign at a smaller population level. So interesting to see how that develops and evolves.
Excellent. And Annie, maybe if we sort of bring comments to a close, just there's so many people want to come in on what you've said, because you've definitely highlighted some areas that we want to focus in on. Thanks very much.
No worries.
Oh, have you finished? Yep. Oh, sorry, I was going to say if just okay, sorry. Sorry. Just one comment, Annie, just based on that, and I think I'm going to give it back to Mike for comment. So it really follows Steve's comments of friendliness, and then somebody put up, but how will we get the one political commitment for reset, as currently HSC can still be used for party gains? Again, a further comment about how we can change the culture. So again, Annie, we do have a 5-party coalition in Northern Ireland. So Mike, I'm going to give you the joy of answering based on what Annie mentioned there about that sort of all of government approach and some of the comments, and then we'll come back to several other parts that Annie mentioned.
So first off, thank you, Annie. I thought the analysis was really helpful, and I think one thing that I would say was that Jim, Mackie, Alan Milburn, Sam Jones, Penny Dash, the people who were largely drivers of the document, they do see this huge system in front of them, and there's a slight temptation to see it as a big rat race where, in order to incentivize the performance, the cheese and the electric shocks need to be put in some of those kind of runways, and then everybody will run through it the way they want. We don't have to do that, and Steve mentioned that we're not that. We don't have that complexity. What we really need to do is to get everybody on the same page, and that is the opportunity of scale that we have, I think, which is much more difficult in an English context, and that gives me a lot of hope and optimism. The point about politics and its role in health, I think, when you're spending the kind of amount of public money that we are in Northern Ireland, and 220 billion, I think, in an English context, it will always be intensely political, and the democratic process is really important. People have talked, and actually NHS England was an experiment in my view to try and move, decisions on health away from politicians. I think that's just not realistic. We live in a political environment. What we have to do is to recognise that politicians usually follow voters. And really what we've got to do is get to voters about the change agenda and what we're trying to do. Because if they're in support, then politicians can support. If we don't have public support, and very often when we talk to the public, we're talking to a small group who feel aggrieved in some cases. What we've never done is have this ongoing conversation with the public about the issues relating to health, what they can do, what their expectations of the system is. So I'm really optimistic about the plan around This Is Health, connecting to My Care, empowering people. And it means that we don't have to have a conversation with the public moderated through political dialogue, or indeed some cases the media. We can go straight to them with a discussion about why change might be necessary, why it's in everybody's interest, and we can listen to what people are saying to us. So I would just say that politics is politics, and we'll always have it, and probably that's quite right. But we need to also have a dialogue directly with the public that isn't mitigated through politicians, so they can support a public mood, not have to, respond to perhaps the angry people who we've let down a bit. So that's the plan really there, Mark. And Annie mentioned she'd be interested to see how we go with it. So will I, but I think we're trying to do the right thing this time.
And I want to thank you, Annie, for being able to contextualise 160 pages of an NHS 10-year plan into a beautiful summary, as well as a comparison with our reset. And just based on that, and I think a nice segue from lived experience. We have several lived experience people on this call, and let's be honest, we are all patients at the end of the day. Kathy, I'm going to bring you in at this stage because I know you've been very patiently waiting. I want to try and get as many people in as possible in the last 15 minutes. So if all our contributors could keep their points quite finite, that would be really helpful. Kathy.
Okay, thank you, Mark, and thanks for the opportunity. It's always not easy for us service users to get a voice and to be heard. So thank you. And I was on Mike's very first webinar when it came into post, and I was really heartened by even then when he talked about engaging with citizens. And I suppose from my perspective, having done involvement now in co-production for like the last 10 years with the department, and also with Western Trust, I think when you talk about using citizens as an asset, I think you're really maybe not appreciating how valuable that asset can be. And I think if this is a plan that you're really going to take forward, and in terms of some of those actions that you're looking to kind of roll out over the next 18 months, I think you really need to be having those conversations with us now. If you look at this from a community development perspective, and my background is in community work, or is in community development and youth work. If you look at sort of like an assets-based approach, they talk about, utilising the strengths of your communities and neighbourhoods, and that I believe is us. And I say that as passionately as I can say that, having done this for the past 10 years and see the value of having service users around the table and hearing that lived experience where we can share with you what works and what doesn't, but also what we can bring to the table is accountability. Like I sit on the Urgent Emergency Care Implementation Board, that's chaired by Jim Wilkinson, I think was on this call earlier, and that's what we're there to do. We're there to ask those questions where we're bringing that different perspective, and we're bringing that voice. And I think when you're looking at bringing change to neighbourhoods and communities, I think it would be a really, really missed opportunity not to be bringing us in at this point. And over the last 18 months, there's really, really good examples of good practice around involvement with the department, through the likes of Barry Doran's policy team, through the likes of the regional community pharmacy group that has been set up by SPPG, where there's tangible examples of change being made as a result of that service user voice. And taking aside the statutory obligation there is to have that service user voice in there, I think that, chief executives, all colleagues in this call today would be really missing an opportunity to hear what we have to say. And I say this not to come across as being disrespectful, but I don't, and I'm saying this not through the likes of the PCC. I'm saying where we need to be around the table, directly linking in with Mike, directly linking in with Mark, directly linking in with our chief executives. And some of us as service users who have done this for the past 10 years are not scared to sit at that strategic level and have our voice heard. And it's whether or not professionals are willing to come along with us and change that culture.
Yeah, thank you, Kathy. And I know Ivan McMinn's on the call, co-chair of the Cancer Strategy. Lived experience would echo your sentiments there. Before I bring Mike back in, there was one other area, because we've got industry, and we talked about industry as well. I really want to see what Marion wants to say from an ABPI point of view, because we know in Reset there was this, we need to work better with companies and with industry and with research, and we are a beautiful pilot case for innovation and innovation studies, which lead to income generation. Marion.
Thanks, Mark, and thanks, Mike. And Mike will certainly be no stranger, hopefully, to ABPI or to industry partnerships, but this is really a very quick plug, to be honest. So in Northern Ireland, we are very lucky to have a health and social care industry partnership framework, which ABPI worked along with MOIC, the Medicines Optimisation Innovation Centre, and was launched back in 2020 by Minister Swan and sort of relaunched again at NICON by Minister Nesbitt in October. And really the point of this is to try and encourage industry partnerships, particularly pharma-related ones in Northern Ireland, because they come with a number of benefits in a system that's perhaps struggling financially or struggling with capacity issues. Industry can often plug some of those gaps. And I know our members are very keen to engage more in Northern Ireland. And I see many projects happening across Scotland, England, and Wales that I would just love to see here in Northern Ireland. And so really for anyone on the call who would like to know more about that health and social care industry partnership and how it works, please don't hesitate to get in touch. We will at NICON in October launch a sort of all-encompassing industry partnership guidance, which will help to explain how partnerships work, and most importantly, some of the governance around those projects, and to build a bit of confidence in working with industry, and that our members very much adhere to a code of conduct on how they work. And just very finally, in the coming weeks, we'll launch a home care report, which will also help to set out some of the benefits of home care. And again, we know that care closer to home is of the utmost importance and can alleviate not just financial pressures, but also some pressures on patients in terms of the burden of travelling, etc. So I'm very happy to share that report when it's ready, and that might spark some conversations about how we can increase that in Northern Ireland. But really, it was just a plug, Mark, for our health and social care industry partnership, and please don't hesitate for anyone to get in touch if they want more info.
No problem, Marion. Tony Docherty, I'm putting you on standby. Any comments, Mike?
Just to pick up on, well, acknowledge Marion's contribution to this, and we will be sort of taking that forward with some pace now, I think. Just to comment on Kathy's point, because the only thing I disagree with Kathy on is that I undervalue the contribution of citizens as assets. I really don't, Kathy. This is an incredibly important bit of the jigsaw. I was involved in work in places like Wigan that showed what you do or what can be done when you genuinely engage people. One of the challenges the system has with speaking to people with lived experience is just the breadth and diversity and the heterogeneity of people's voice. And so we do need to sort of find structures and ways of connecting to people. And I had the joy of speaking to the Northern Ireland Health Collaborative last week, it's the week before actually. And, my commitment to them was, look, not only will I try and make sure that you're connected to policy and the way we think about things, but that'll be reinforced at local level where our trusts have responsibility, ensuring that, those voices are heard. And not just on the back of change, but actually proactively heard around redesign of services, not reactively on change of services. So, yes, I hope that colleagues who are today from VCSE organisations, do feel that we're now creating that culture where this is the way we do things. it's not just a line in a reset plan. This is increasingly the way that we do things, is that partnership, that engagement, and that listening. But logistically, it remains a challenge, and we have to try and get to be as good as we can at that.
And I think that's a point, and I see Gillian Lewis is on there from Northern Ireland Collective, and it's a point that we all have to keep reminding ourselves on, and it's back to Steve and Mike mentioning the size of Northern Ireland, yet we do have many different fragmented groups trying to compete in the same arena. And maybe in the same way as we're having a collaborative approach in committees in common, that we have that same collaborative approach from our arm's length bodies. Little challenge out there. Kathy, quick return, and then I'm going to go back to Tony because he has an ask of Mike.
No, I just very quickly pick up on what Mike is saying. It's very difficult in terms of making sure that all those voices are represented. But if there's an opportunity to come and give you a few ideas on how you might do that, then I'm wondering, is that a possibility? If somebody could do something to help make that happen, please. If you don't ask, you don't get.
Absolutely, Kathy. And Tony, you have mentioned, again, forgive me for trying to get as many people in as possible. I'm going to go to my hometown of Stroke City, and Tony, Healthy Living Centre Alliance. Do you want to just give a few words about what you put in your text and the ask of Mike?
Yeah, surely, Mark. I think it was you actually that recoined the phrase, or certainly it was the first time I heard it, was culture eats strategy for breakfast. And it struck me like a thunderbolt when you said it, by the way. And that was in the context of the integrated care partnerships, probably around 10 or 12 years ago. I work in the community sector. I have done for around 30 years. I tend to think that we can work collaboratively, innovatively, and so on. But I have to say, I found the environment quite difficult. If you're not actually part of the health and social care family of organisations, it's very, very difficult to get a toehold on what's going on or to make progress. My organisation, the Healthy Living Centre Alliance, still has a lot of highly skilled people who are experts in delivering social prescribing. We don't have a network anymore because we couldn't afford to upkeep it, and we couldn't get anyone within the public sector to listen to us. So I'm very, very pleased to hear that the social prescribing might be back on the agenda, and we have an ongoing discussion with primary care at the department about how the community sector and social prescribing could become practical sort of collaborators in general practice and MDTs. So very intriguing, I have to say, very intriguing.
And Tony, in terms of foothold, the Grasping the Nettle webinars is only one facet of NICON. There's the NICON conference as well. And, one of the joys of this is it is that opportunity to have the length and breadth of our society, those in leadership, those in arm's length bodies, the voluntary community sector. We might even get an additional politician the odd time to have these conversations. Mike, any reflections there? And will I give the last word to a general practitioner, Nicola? We'll have to wait and see. Mike.
Yeah, so look, I really understand and really appreciate people's desire to be part of this. And what I would say is, if you've heard anything on this call today, on this webinar today, that gives you a sense of I could help with that, or I could avoid them making mistakes, or whatever it might be, then please do let us know, either through Heather at NICON, because NICON are our significant partner in this. They bring together everybody, or do drop me a line. I mean, there's a bureaucracy associated with being a permanent secretary, and so sometimes it takes a bit to get back. But, everybody's contribution here really matters, and please do drop me a line. I will certainly try to make sure that I can meet people. We might have to invite people to a collective meeting rather than me meeting everybody individually, but And I'm more than happy to leave this wonderful office that I inherited in Stormont and come out to people. That's kind of the way that I work. So look, just let me know if you've got anything that could help me. My job is to create the right context in which everybody out there can do their bit. It's not to be the only person in the world who's bothered about this. So it's all about context. Those ideas are great. I'll respond. Let's do it together.
Thank you so much, Mike. And just before I bring our chair in to close, because we are in the last 5 minutes, Nicola. Microphone, Nicola.
Can you hear me now?
Loud and clear.
Thank you very much, Mark, and thank you, Mike. This has been a really, really interesting meeting. Just to put in context, I'm a GP up in Derry. I'm also the GP Associate Medical Director in the Western Trust, and I've been working with the practices that the Trust has been given the contracts to hold over the last couple of years. So I kind of really understand the sharp end of both secondary and primary care and the interface between the two. My concern, I suppose, I think the reset plan, we all understand why it's so essential. We understand we can't just keep throwing money at health and not getting better outcomes. The concern would be that the reset plan, I suppose the main driver of this is the severe pressures in secondary care. We all know about the waiting times in the emergency department, the lack of beds and everything else. However, if this reset plan is dependent on shifting care back out into the community, as you know from being a GP, that at the minute we are beyond breaking point out in general practice. And I think it would be good to hear what the plan is to improve the resources in primary care in general practice, because GPs, it's going to send a little bit of panic waves, I think, to colleagues if the feeling is that this reset plan is going to increase the workload in an area where people are it's already breaking down. I think this is possible and it's doable, and it probably is a tweak rather than a massive revolution. I don't think revolutions are a good idea. I think evolution is much better in general. So I think GP partnership practices have been key and central to the communities in Northern Ireland, and especially in the rural communities. It's a bit like the post offices and the corner shops. We're at risk of maybe those disintegrating if the pressure gets too much. So thank you so much for the interest that you have in Northern Ireland and in the health service and improving it. I'm just, I suppose, a little concerned that maybe of the reliance on the community-based healthcare and the community services, all of which are incredibly fragile at the minute. And many of the community-based services, as Tony Doherty knows, they've actually lost their funding recently. So it's hard to imagine how we're going to be able to actually shoulder the burden of this care shift into the community unless things change.
Sure, and I'm going to bring Mike in. Just one wee thing to say, 2 plugs. One, we intend to do a Grasping the Nettle webinar on primary care and all of its challenges. And 2, if you look in the chat function, there is a link for a primary care lead to work specifically with NICON. Mike, maybe, I know it's very hard in the last couple of minutes, but maybe just 1 or 2 points before I go to Jonathan.
Yeah, I mean, I think Nicola's point is a really important one. And I would want to make this very clear that this is not about shifting workload. This is about shifting resource, focus, emphasis, the ability to diagnose soonest, the ability to get the work into the right place with the right skill mix. And I believe that there is a huge amount in this plan that is supportive of progressive general practice, which is fit for the future. And I would just really hope that in the discussions about resolve our current disputes, we absolutely get ourselves all around the table with our federations, because scale matters as well, Nicola, in terms of the future of general practice. And along with Barbara Starfield's work on continuity of care, but we also have to think about what a future model looks like, and that's fit for the next 20 years. So I'm really up for that conversation. It's not about shifting work to GPs who are already stressed. This is about a broader base of approach to progressive out-of-hospital care, funded resource properly, including resource coming from acute care into community settings. So that's what we're about. But listen, just to end on the point, Mark, I've said it many times, you know, we need everybody to contribute ideas. This is a framework within which we can work. There is fantastic support from I think all sectors who want to make this work. Steve's point about superpower, you know, friendliness is one, the other is a commitment to work together to deliver something better for the people of Northern Ireland. And we really do have that. And even where people are concerned, it's in the spirit of how do we resolve those concerns. So I'm absolutely delighted about the response. Thank you for people's time. I hope to work with you on implementing it rather than just setting it out in a document.
And I think Thomas McKeever sums it up. I think that already Mike's skill and ability and honesty are restoring much needed confidence and hope. Amen on that. Before I close this conversation, this inspiring to greatness, we know we can do it, guys. In Northern Ireland, we just got to get on and do it, and stop the process-driven delays that seem to cripple us. So we know we can do it. But just in terms of this webinar, it is recorded. It will be distributed to all. The chat function has been extremely helpful in linking people and evidence base. And behind that is Vicky, Megan, Thomas, and our policy lead, Robin, who have been working away in the background, not least Heather. So I just want you to indulge me for one more minute after a massive thanks for everyone and their comments, just to hear from one of the chairman of the trusts and also the chairman of NICON, Jonathan. Will we do a drum roll, Jonathan?
Preferably not, Mark. Thank you very much. But well chaired again. And thank you to everybody for your patience. It's been a long session, but a great range of voices in again. Permanent Secretary, thank you for your time. It's a great opportunity to use NICON across the ecosystem here in Northern Ireland to get that message out. And we at NICON for the last 4 or 5 years, when I've been actively involved, this is the ecosystem we've been trying to create and nudge and cajole and nurture into place. And we're here at the dawning of it. We wouldn't have that without you, and I think we as a coalition of the willing across the screen need to get behind this reset plan. The chairs are across the HSC system, and when I talk to people in England from industry and from entrepreneurs, they see this as the Goldilocks place. It's the ideal size, it's the ideal place for testing things, for progressing, for change. It's been referred to before by Steve and Siobhan. 1.9 million people. For goodness sake, most of us are on first name terms with the whole leadership of every aspect of health and social care, primary care, right across the system. If we cannot do it here and now in Northern Ireland, we will never do it. The timing has to be right because it will crash and burn if we don't do it. And boards, I think, will be stepping up. I think there'll be more difficult questions asked, not just by politicians, but I think the Minister has put a range of people across boards right across the system, and I think they will be more exercised about holding to account and making sure that boards do the work across the system. So thank you again for participating. It's great to have you here. This is so vital. These webinars, it gets this message out and creates the voice, and as I said, it creates the coalition of the willing. This has to be a time for change. Thank you.
Thank you all very much, everybody. Have a lovely evening. Thank you.
Thank you.
Thanks, guys.